important that the implant should be placed at the three-dimensional implant position based on three-dimensional consideration. Medial-distal consideration of distance from tooth, pontic or implant, depth and direction down to 3 to 4 mm. Direction is the edge of superstructure, buccal lineal in 2 mm, and consideration of buccal bone width. In my opinion, it is preferable that the axial direction stays within the edge of the superstructure, because if the implant is inclined buccally, it may cause disharmony of the superstructure cervical line and risk future gingival recession. Look at this case. Left maxillary center incisor was hopeless, causing the root fracture. Orthodontic extrusion was performed before implant placement. I used my original bar kit along the parietal wall in the socket and confirmed the axial direction. My bar are used as the initial drill before twist drill. This slide shows the final result and periapical X-ray. These three cases are examples of the condition of the first examination. Here you can see the implant direction is not inclined buccally. Therefore, in my opinion, it is very important that direction is part of the 3D formula for a successful aesthetic outcome. Especially, the axial direction is important for immediate implant placement into extraction socket. I already show you the importance of three-dimensional position. However, are these existing factors enough to get optimal outcome? Achieving optimal aesthetic result. To go beyond utilizing the most appropriate clinical technique and instrument, I felt we need to think about an additional factor associated with the timing of procedures during the treatment sequence. I propose we should include the selection of the optimal timing of each clinical procedure as a new fourth factor. Here are the clinical procedures we can list up: tooth extraction, preservation or enhancement of hard and soft tissue, fixture placement, abutment connection, tissue modeling with a provisional and or a modified abutment, and final restoration. For every single procedure, we need to consider the optimal timing. Here I would like to postulate and introduce a novel 4D concept of implant therapy by adding a new factor of timing to the existing three factors. Now I will show you the three procedures of how we apply this 4D concept in implant dentistry. Extraction of tooth in the anterior maxillary area causes a labial bone resorption, which makes it difficult to place an implant at the ideal position and causes a failure in their aesthetics. Therefore, strict examination diagnosis should be made while failing teeth are still in the mouth. Let's discuss the timing of extraction and implant placement. They are categorized three procedures: immediate implant placement, early implant placement, delayed implant placement. First of all, we should understand the indications and limitations of immediate implant placement. For preserving the buccal bone, as you can see, maxillary right center incisor was fractured. the implant was placed into the extraction socket. The superstructure was not achieved to symmetry cervical line, but this patient was satisfied because he has a low smile line. So why does the last case have a long tooth on the implant? What do we know? What can we do for the immediate implant placement? First, it is important for us to understand the differences of biologic width of a natural tooth and an urban implant. In the submerged implant which I used, the biologic width starts from the flat top. Bone resorption will occur in all four walls. This is a very important finding. Secondly, Dr. Wilson and Dr. Boozer reported that if the gap between the extraction site and implant diameter is smaller than 1.5 meter, it is predictable without bone graft. In my criteria, molars are not indicated to immediate implant placement, but premolar and anterior teeth are. In my clinical treatment, I recommended orthodontic extrusion for Japanese patients for immediate implant placement. Advantages of the orthodontic extrusion are to minimize the postoperative alveolar bone resorption and gingival recession, and to help obtain the sufficient bone volume at the apex for primary stability. Another advantage is to minimize the gap between the implant diameter and extraction socket. I would like to introduce my and Dr. Morris' classification of an immediate implant placement. First, we need to reconfirm whether the buccal bone is intact or not after orthodontic extrusion using bone sound technique or CT scan. Class 1. If the buccal bone is intact and biotype is thick, we can perform flapless procedure for the immediate implant placement. This is the above mentioned case. After extraction, intact bone was confirmed and biotype was diagnosed as thick biotype. The implant was placed on the parietal wall into the fresh extraction socket, and the graft materials were filled in the gap between socket and the implant diameter. The provisional restoration was set immediately. 4 months after implant placement, the custom abutment was fabricated using the UCLA abutment. This show final result and periapical X-ray. Okay, let's look at the class 2. If the buccal bone is intact and the biotype is thin, we had better to perform flap procedure with simultaneously connective tissue graft technique or staged connective tissue graft technique. Now look at this. We can see among tattoo and root fracture on these tooth. The tattoo on the surface layer was removed. A core tape was placed and the emdogain was applied. The lower right slide shows the condition 1 month after the surgery. The deep tattoo stitch in the buccal and the parietal side was removed and connective tissue graft was performed. Thereafter, an orthodontic extrusion was performed. How far should we perform the orthodontic extrusion at least? How much gingival tissue and labial bone are lost? Dr. Turner et al. Reported that it seemed about 1 millimeter, and most of it occurred on the buccal side. I will show you my criteria. gingival margin level should be 2 mm higher than the clinical CEJ. Alveolar crest bone should be 3 mm below gingival margin, and the implant should be placed 3 mm below clinical CEJ. These three positions are crucial for flapless immediate implant placement. 2 months after implant placement, final abutment, zero abutment was set, and the provisional restoration was set and adjusted. And this is the final result. Dr. Khan and my friend Dr. Metz et al. At Rwanda University published this article. In conclusion, the level of the interdental papilla is related to the alveolar bone level of the adjacent tooth. The most important point in this study is that the mucosal dimensions of the thick biotype were greater than those of the thin biotype. In summary, the thin biotype suffers recession more easily. Furthermore, Dr. Glunder published this article last year. In medial-distal view, the distance between the implant and the tooth should not be less than 1.5 meter. In buccal-lingual view, the 1.5 meter wide crater will also appear on the buccal side. He reported that the bone thickness should be at least 2 mm at the buccal side. The slide meanwhile illustrated Dr. Maynard's classification. It explains the risk of future gingival recession in relation to gingival teeth and alveolar bone. Type 4 with the thin bone and thin mucosa has a higher risk of gingival recession. The last report by Dr. Glunder stated the bone width should be at least 2 mm. However, if not, we need to perform a connective tissue graft for immediate implant placement. The technical manipulation that we can do is to improve type 4 to type 3 condition by connective tissue graft. By doing so, this technique will be able to prevent further gingival recession. Now look at this case. We can see the traumatic intra-root resorption in this tooth. In this patient, all surrounding structure remained intact, but the crown portion of the natural tooth was removed and bonded to root again using superbond. Then the orthodontic extrusion was carried out. The tooth was carefully extracted using periotom. After confirming if the facial bone removed intact, the implant was placed in proper position. This case demonstrated the rotational flap technique from the palate. This case was improved type 4 to type 3 condition. This should a periapical X-ray, first dental examination, implant placement, 4 months after implant placement. I adjusted provisional realization and final result. Now let's turn class 3. If we expect to place an implant within the bone housing, although we recognize the damaged, compromised buccal bone, we can still place implant with GBR and simultaneous connective tissue graft or stage connective tissue graft. I would like to show you a limited case for immediate implant placement. In this case, we can see a root fracture at the buccal side. Although a labial bone is absorbed, you can see the implant within the bone housing of alveolar bone from the occlusal view. After the graft materials were filled and the reservoir membrane was pressed, Kurdish graft technique was applied. After 2 months, this site was cut open with semilunar incision. The final abutment and visualization were pressed, and tissue scalping technique was applied. This is the final result. She was satisfied, but we can see an insufficient bone volume at the buccal side. In case 3 of immediate implant placement, we had better to perform staged approach for aesthetic result. Finally, class 4, if we can place implant within the parameter of bone housing, we should discontinue immediate implant placement. Now we can see the classification of an immediate implant placement again. Class 1 and Class 2 are indications for immediate implant placement. We can preserve the buccal bone at the implant site. Class 3 is a limitation for immediate implant placement. Class 4 is a control indication. Basic understanding for the indications and classification for immediate implant placement. How was this case treated? Firstly, 2 implants were placed at the right lateral incisor and left incisor position was with GBR after orthodontic extrusion. 3 months after implant placement, final ZUCLA abutment was set. Orthodontic extrusion was carried out at the left canine. Then, GBL and Kurdish graft was performed and right center incisor was extracted. This slide shows the final result and periapical X-ray. Conclusion. Immediate implant placement should be used to preserve the buccal bone at the earliest opportunity. For the concept can be effectively achieved through the understanding the indications and classification of immediate implant placement.